Great. Well, I want to thank SAGES and the committee chairs for inviting me to talk this morning. So training and credentialing, at least in endoscopy, it continues to evolve. And I think with the new field of endoluminal primary bariatrics, we have to continue to really figure out how do we train individuals. I have no relevant disclosures for this talk. So training, as you guys all know, many of you that are still in residency or fellowships, has really changed quite a bit. And credentialing right now, it continues to evolve for many of us. And it really are two different areas that I'm hopefully going to at least shed some light into. For residents in training, obviously we know that there's a lot of restrictions on the amount of time that they can spend in various surgical training that is probably limiting their exposure to not just the complex procedures, but some of the basic things that we want them to get out of. And there's a lot of numerous studies out there that looked at least surgical training and how often our trainees not only get the core procedures, but some more of the complex procedures. And unfortunately, if you look at those publications, the majority of residents currently coming out of residency are going to be underperforming in many of the core procedures. In this one study, only 69% of the core procedures were performed in a mean of 5 times, with a lot of other procedures being less than 1 procedures. So training residents in not only common but uncommon procedures, and what we'll hear later on, the complex procedures, is going to present an additional challenge. And we're not talking about basic endoscopy, we're going to be talking about some of these complex procedures. So we know that most residents now graduating from accredited surgical fellowships choose, or from residencies choose fellowships. And if you look at the number of applicants that are now at least looking at the endoscopic and laparoscopic fellowships, we have a significant pool with a number of those programs getting filled. General surgery residents in general now are getting less experience for those procedures, and when it comes to endoscopy, the majority of them are not meeting the requirements, at least for many hospitals and many labs to meet the numbers for credentialing or privileging. And still, majority of surgical trainees, when they go out to practices, utilize endoscopy as a large part of their practice. And studies have shown that general surgeons really provide up to a third of their cases in the field of endoscopy. And if you compare the training that our surgical residents get to many of the other training in endoscopy, which are the GI fellows, unfortunately, numbers, if you look at numbers alone, you can still see that our residents in training get a far less number in procedures that we consider to be basic, upper and colonoscopy. So we do have a disadvantage when it comes to numbers in comparison to our GI colleagues. The national average for endoscopies as a surgeon chief and surgeon junior, if you put them together, most residents graduating are getting just at the number of 35 upper endoscopies and at 64 lowers, and these are recent numbers as well. So what do we do as individuals that are looking at getting better training for our trainees? SAGES has put together a number of curriculums with the FES. That curriculum, as many of you know, is both a cognitive assessment that contains multiple choice answers, as well as a simulator through the GI Mentor. It takes approximately 40 to 60 minutes to do the actual simulation, and at the end of that, you're going to get a certification in basic endoscopy. And simulation has become a big part of training for endoscopy as it is in laparoscopy, and it's taken a greater role in also certification. And so the benchmarks for really determining competency are also, as you know, are moving away from the numbers that you've seen, and hopefully going to more of a training to competence. So GI Mentor is, again, part of the FES. If you look at simulators, at least in endoscopy, and comparing the use of simulators to individuals that haven't used simulators, the objective for a majority of studies out there do find that the learning curve is expedited when you start to use simulation prior to going into real patients. So competence, again, is shifting away from numbers. We're looking at validated evaluation tools such as gauges and then appropriate clinical judgment. And that's been the hallmark of the American Board of Surgery, going towards proficiency with competence. And competency, as you all know, and credentialing are two different things. They're not interchangeable terms. Competency really is the consistent ability to meet the technical goals of the intended procedure, as well as understanding the cognitive aspects of that procedure. And credentialing still is at the local and regional level that looks at proper license and education that's adequate for that privilege within that institution. The fundamentals of endoscopy curriculum has now been put in place for all surgical residents. This is what combines didactic, simulation, clinical experience, and objective skill assessments. Each residency now is required to have a fundamentals of endoscopy curriculum as part of their general surgery curriculum. And residents have to go through this, they have to complete it, they have to be documented by their program director, and prior to sitting for their boards, this has to be completed. Now, credentialing is a different thing. If you look at two recent publications from our leading surgical societies in endoscopy, ASGE still is utilizing a minimum number of cases, and SAGES has, again, shifted more towards competency, and those documents are listed here. They were recently published in 2016, and the one from ASGE just got published in February of this year. If you look at the postgraduate training, that's also shifting as well. And these are really for individuals that didn't meet the initial criteria or having the opportunity to go through a curriculum that was part of their surgical training or complete the FES. That's changed. There are societies such as the American Surgery of Metabolic and Bariatric Surgery has now developed a credentialing document for endoluminal bariatric therapy. Many of the things that you'll hear about this afternoon. And that is also held the same premise that you have to go through some formal didactics prior to having a credentialing in bariatric endoluminal therapy. And how that's going to roll out is still in evolution, but for many of these, it's going to be based on the procedure that you're doing and seeking out the proctoring from a preceptor that's going to help you facilitate that learning. And proctoring really is, again, going to be observational assessment of the skills by that endoscopist, and the role of the proctor is really to act as an independent, unbiased monitor for evaluating each task, not necessarily teaching it, but being able to evaluate the technical and cognitive skills for that. Certification, which is a different area, is still in evolution as well when it comes to endoluminal bariatric therapy, but it really is it's an endoscopic overall experience by a skilled endoscopist practitioner that's completed a residency fellowship in that, and then there's going to be some informal training that they may need to accomplish for more advanced or major skill acquisition prior to being able to get privileges for that procedure. The SAGES has put together an endoluminal bariatric task force, and that really has a set of guidelines that are really going to help members understand what it's going to take for them to be able to understand bariatric therapy from an endoluminal standpoint. Our society, SAGES and ASMBS, are developing a core curriculum for bariatric endoscopy. This is a didactic type of a curriculum that's going to have various modules for members to complete, having a form of an examination, and then having a hands-on lab demonstrating the essentials of bariatric endoscopy as part of the charge for both SAGES and ASMBS. Last couple slides are really talking about privileging, and again, I would reference back to the guidelines of the local director or region, and many of these guidelines for privileging are going to be at that level. If you look at most of endoscopy in the U.S., close to 50% of that privileging follows the ASGE guidelines, and the other 40+% follow some form of local privileging, and they utilize documents such as the SAGES document as well. So that's going to be, again, at a local, regional level. And most of that is really going to be dependent on the endoscopic director of these labs, and if the majority of them are going to be GI physicians, they're going to be utilizing the ASGE document and maybe not necessarily the SAGES document. So in summary, there are no numerical standards that define competence, at least in endoscopy. And most surgical trainees, current trainees, look at the American Board of Surgery and the flexible endoscopy curriculum and FES prior to sitting for the boards. If you're trying to acquire new major skill sets, such as you heard later on this morning, that's going to be continue to evolve, but our societies are working together to try to develop what that certification is going to look like. And it really has to be a standardized assessment of technical and cognitive skills across all specialties. That does also include the gastroenterology specialties. That's separate than your hospital privileging, which again is going to be really at the more local level. Thank you very much.
So we're going to open the floor just for questions for Bipan. He's going to be off to our endoluminal lab, so he won't be able to stay for the expert panel at the end. But any questions from the audience for Bipan?
Well, great.
So I have one for you. I'm not going to let you off that easy.
That was off.
So we're going to hear about a litany of devices, and my expectation is that with the rapid development and different targets, there's going to be a slew of different types of devices that we're using. We've seen that already, and we're going to hear about that right now. But as you see training for these, for kind of the surgical endoscopist, the bariatric surgeon, the gastroenterologist, do you think that we're looking at a broad set of skills that will be widely applied to different devices for competency and training? Or are we looking at very specific device-related criteria, like credentialing for placing a lap band? How do you see that in the future?
Yeah, I think it's gonna evolve. What I think we should really do for our members is really, first off, try to make sure that the playing field is equal amongst all individuals that are really in the bariatric endoscopy realm. So before you can jump to, I think, these major new skill acquisition, like many of these devices are gonna offer, you have to have the fundamentals. And I think the majority of us have those fundamentals through our current training program, but many of us that are postgraduate may not have acquired the necessary requirements. So I think you have to look at first developing the fundamentals of bariatric endoscopy, and that's relatively new. What I'm doing today wasn't necessarily what I was doing 10 years ago. So I think that field is so rapidly evolving that we have to go back to making sure that the fundamentals are there. So I think you have to have that first. Any new device, as we all know, that has to go through a regulatory board has to require that the individual is proctor or preceptored in understanding not only the placement of that device, but understanding what the complications of that device are going to be. So I think that's fortunate for us because you do have to have some type of preceptorship in that particular device. But as we all know, placing some of these more complex devices may lead to complications that if the endoscopist isn't able to handle because they don't have the fundamentals, then I think there's a gap in our knowledge. So I think SAGES and our other societies are doing the right thing in developing that core competency, that certification in bariatric endoscopy, not just with the didactics, which many surgeons have, but also with some of the hands-on that really teach the fundamentals that can hopefully set the platform for these more advanced procedures.
Great. We'll take a quick question in the back while our next speaker comes up.
Daniel Ziegler, Fort Worth, Texas. I still see a conflict between gastroenterologists and surgeons who do endoscopy as far as getting privileges. If you have an endoscopic director who's a gastroenterologist, I mean, some of them have not been receptive to having surgeons do endoscopy. And is there something that can help resolve the conflict?
Yeah, you're absolutely right. I mean, if you look at the majority of endoscopy centers, these are either individual, freestanding, and hospital-based. The majority of them still use the ASGE criteria, which is really a numbers-based criteria. As I'm not sure if many of the audience know, that was recently just republished again in February of this year. And it kind of went against what most of the surgical societies, at least SAGES, is saying for the credentialing document as well. So I think what we should do as an endoscopist, as a surgical endoscopist, if you're having that struggle with your hospital, I think you have something. There's a document that can be used in saying, well, wait a minute, I completed my core endoscopy required through the American Board of Surgery. That's a recognized document. I have SAGES guidelines on credentialing that it's different than the ASG guidelines, and I think you have enough to say there's different credentialing documents, and they have to be looked at differently. But unfortunately, 50% plus 54% of the actual labs in the U.S. still use that ASGE document. So I think that is the difficulty. But we do have enough information to say that numbers are not necessarily where we need to look at for competency.